So good morning, everyone. Thanks for joining our virtual walk with the future doc. And here are dogs, sorry. So my name is Lauren. I'm a fourth year medical student at WVU. So just gonna take a few moments to kind of go over what to expect as we walk together virtually over the next hour. So today we have Dr. Samantha Deamer. She's leading the conversation about the topic of the mind-body connection, disease, and our mental health. And then as we all walk together virtually, we'll open up the conversation for questions and discussion. So everyone should have received a pop-up notification through Zoom, and that's to consent to the recording of the walk. And only the audio portion of the recording will be made available publicly on our YouTube channel, which is WVU Walk with the Future Doc. And we also have on our YouTube channel previous walks that were also recorded if anyone would like to listen to those. And then also our Facebook page is the same name, WVU Walk with the Future Doc. And this is the best place to look for updated information about future walks that may be coming up. So thank you everyone for joining us today. Sorry, we get past the dogs. Thank you everyone for joining us today. Now I'd like to introduce everyone to Dr. Samantha Deamer. She is a postdoc fellow and supervised psychologist with WVU's Behavioral Medicine and Psychiatry in Martinsburg, West Virginia. We're excited to have her joining us to speak about the topic of the mind-body connection, disease, and our mental health. So with that said, I'll mute myself with all the dogs barking and let her begin.
I think you're muted, Samantha.
How long have we been doing Zoom? All right, well, good morning, everyone. This is a cool program that you guys have, and I'm excited to be joining you. I have my security detail here, my husband, and we're walking around our complex, so there may be some background noise, but I'm glad to be here. So like Lauren said, I'm a clinical psychologist in my fellowship year, very similar to like a second year medical resident. And my current work is half in traditional outpatient behavioral health care, and then half in integrated primary care in our residency clinic in Harpers Ferry, West Virginia, which is really cool. I get to learn alongside the residents and collaborate on patient care. And that's kind of what inspired the disease and mental health connection talk today. Patients come in with a variety of conditions, from chronic illness management to typical mental health concerns like mood and anxiety, things like smoking cessation or lifestyle changes. And we know that our behaviors and our emotional mental health really impacts our health outcomes. So that's what I plan to talk to you guys about today. Being a clinical psychologist, I'm much more familiar with how our behaviors and mental health impact our health. But I have a few points on how some illnesses and diseases impact our mental health as well. So I'm happy to, I don't know if it's allowed, but happy to take questions as we go through or interruptions. So I'll just get started. The way I broke this up is kind of into categories of illness. So the first one, probably our biggest referral question at Harpers Ferry, is just depression, low mood. If patients come in to see their primary care physician and depression is one of their primary concerns, an often occurring situation is that I'll get pulled in to meet that patient and talk a little bit about their treatment options and things that we can provide for them. Sometimes that looks like their primary care provider prescribing some kind of antidepressant or medication. Sometimes they choose to do a few sessions of behavioral therapy with me in the outpatient clinic. And as we're kind of collaborating together, that are on my mind and the physician's mind, is to look for some diseases that might be impacting mood. So some of these most common conditions are things like endocrine disorders or hypothyroidism, some viral infections, cancers, specifically pancreatic cancer, and then some vitamin deficiencies like B12. So being there in the primary care office is super helpful because we can collaborate together, and the lab is right there, and we can work on both the mental and the physical concerns at the same time. There's also some degenerative diseases that can impact your mental health. So in patients with Alzheimer's, we can see low mood, Parkinson's disease. If we have head trauma or recent TBI, we can see some mood changes. So really being able to collaborate together as a team for those cases is helpful. And the reverse relationship exists too. So we know that people who have mood concerns or anxiety have, in combination with chronic illness, have poorer health outcomes than if they were just to be managing chronic illness on its own. So we also know that if someone's trying to manage depression and also juggle managing their care, that can be pretty impactful. So my role can just be treating that depression as their physician works with them to manage their healthcare. The second most common referral I get is panic and anxiety. And this is probably the most common hospital follow-up that I'm directly involved in. Folks that have panic attacks and go to the ER and get discharged back to their primary care provider. If they've run some tests and they're not finding anything, me providing some psychoeducation about panic and anxiety and just giving them some coping skills and talking them through that is something that I typically do. And I still encourage all patients, if they're having those symptoms of panic, hold on. Hey, security, can we sit down a little bit? It's hard to walk and talk. Whew. What was I saying? Oh, anxiety and panic. I encourage patients that have those typical symptoms of panic, like the heart palpitations, trouble breathing, sweating, all of those things. If it's sudden and new and it's first time, to definitely get that checked out and seek some professional medical care, because there's lots of physical diseases that mimic anxiety as well. So being able to work as a healthcare team and tease apart what's going on is really helpful. So anxiety specifically, if we've got conditions like hyperthyroidism, we can see some anxiety. Some medications can cause some anxiety symptoms. Other things like Lyme's disease, there's some herbal substances, there's all kinds of things that can cause anxiety. So in general, if patients are coming in with sudden anxiety, they don't have a history of it, they don't have a family history of anxiety, and nothing's really changed, there's been no recent life stressors or changes, looking into what physical conditions might be manifesting as anxiety is something that the healthcare team and I can work together to do. Some of the other things that we treat pretty commonly in our primary care setting is just standard lifestyle management or lifestyle changes. So things like smoking cessation or weight loss, managing sleep, managing chronic conditions like diabetes. There's lots of things going on in our world and in our lives that can really impact our ability to do those things effectively. So for example, smoking cessation, we know that there's lots of psychosocial cues in our environment that can really trigger some urges to smoke. So for the person who just quit but used to smoke every morning with their cup of coffee, it's likely that those morning coffee cups are going to be a good trigger for the urge to smoke. So being able to sit down with patients as an extension of their primary care provider and talk through, like, what are your social and environmental and emotional triggers, and how can we manage those things and be prepared to tackle them when they come up, is some things that we offer in primary care as well. So that's about all I have. I can ramble on about a lot of other things, but are there questions?
Sure. So now I'll kind of open it up for questions. So thank you so much, Dr. Deamer, for giving us a great start to the morning with a great topic for us. So now I'll open it up for questions. So how we do this is you can send your questions in the chat. You can send them to me. My name is Mia, and I'm a third-year medical student at WVU. Or you can send them to everybody. in the chat room, and I'll just make sure that they get read out loud. Or you can unmute yourself and ask your question out loud if you feel comfortable with that.
Dr. Deamer, I have a question.
Hi, Dr. Creasy.
Oh, I didn't know if you recognized my voice.
I can see your name too.
Oh, darn it. Well, I'm driving right now, so I can't actually walk, but I am curious, what kinds of other cases do you see at the doctor's office? What kinds of cases are the primary care doctors referring to you?
Yeah, all kinds of things. So again, the most common are depression and anxiety. We get quite a bit of trauma cases sent our way as well, like PTSD. Other things that are common referrals are sleep. Hold on, sorry. Sleep problems, or managing diabetes, managing weight loss. I'd say those are the biggest ones. I'd like to get more chronic pain referrals. We're not getting a ton of those right now, but we're getting there.
Can you explain kind of how that works then, if a doctor refers a patient and does maybe a warm handoff and that kind of process?
Yeah. So the model that we use in Harper's Ferry in our residency clinic is a shorter term therapy model that includes something called a warm handoff, like Dr. Creasy said. And this is the primary care physician's ability to just find us and literally drag us into the room with the patient in that moment in their appointment. I've worked at a few other integrated primary care settings, and sometimes that could be they have a patient on their schedule ahead of time and they're like, can you go in ahead of me and just meet this patient and introduce yourself and let them know what you're up to? And it can be, hey, I just saw this patient, they're finished. Can you wrap up with them and see them for a few minutes? If they consent to being seen that day and I have the availability in my schedule, sometimes I'll take them for their first appointment that day so that we know we're getting them when they're there. Their follow-up is 100% because they're already there. We're not scheduling out. And we can do some good work right there while they're already in the office. When I introduce myself to patients, I explain my role, that I'm a clinical psychologist and I'm there to support healthcare however I can and support their physicians. And that means that I'm going to be collaborating with their physicians, and we're going to chat about what I've learned and what our plan is, and work together to really get them feeling that they're in a place that they're just functioning the way they want to be and functioning better in certain areas. And then after I see them, I try to find their physician and loop back around either through a my chart message or a chart forward, and just let the patient or the provider know what we've been working on and what my recommendations are. Thanks for the question, Dr. Creasy.
And so what's kind of the typical or average amount of sessions you would see a patient at that type of setting?
Yeah, I would say the modal is 1. So on average, I probably see patients 1 time. And that might be 1 time per episode. So maybe I see them once this week, but 6 months from now, they're seeing their PCP again, and I pop in again, or they request an appointment with me. So it's more of a population health approach instead of a traditional intensive therapy approach, in that we see the same patients over the course of their lifetime, not necessarily for a period of 3 or 6 months and then discontinue. I would say the maximum amount of time is probably 5 or 6 sessions and 30 minutes for each. So it is much shorter than traditional outpatient therapy. And we have pretty great outcomes too, especially since we're catching them when their symptoms are usually pretty acute and they're getting care when they're highly motivated and they're right there in the office ready to go and work on stuff.
So it sounds like in many cases, you're treating this as if you may not see them again, because many times they don't show up for the follow-ups.
Yep, absolutely. We first session, I try to make a plan with them immediately, give them some coping resources if that's what they need, teach them some ways to catch thoughts that are unhelpful. Maybe start a conversation with their doctor about treatment options. So we try to make sure the first time we see them, we're giving them something that they can practice and work on.
It's something that also might be helpful for the audience here is, or maybe a couple of handouts on anxiety and depression treatment that you would give out.
Yeah, yes.
And so you might be able to post those. And,
am I able to?
Yes, yeah, so what, Dr. Deamer, why don't after the walk you like email them to me and then I can post them to our Facebook page?
Yeah, absolutely. I've got a couple that I use all the time, so I can post those few.
Sure, we would love that. And I do have quite a few questions for you in the chat. This is awesome. People are really engaging in the topic today. So the first question is, could you please elaborate on what cognitive behavioral therapy entails?
Yeah, I love that question. Cognitive behavioral therapy is kind of what it sounds like, a combination of cognitive and behavioral interventions. So for example, if someone is coming in with depression as their primary reason for seeing me, we might try either one after another or simultaneously some cognitive and behavioral strategies to improve their mood. So with depression, we typically see, and this is on one of the common handouts that I'll send you, Mia, but we typically see this spiraling effect of mood that comes from, like when you're depressed, you have lower energy, you have lower motivation, you're just feeling kind of bleh. And then usually people respond to that by sleeping more or neglecting things that they normally would do, or just not doing things that they would normally enjoy. And then they feel even worse, kind of guilty, ineffective, their mood's even worse, they're more tired, it just kind of spirals down. So cognitive behavioral therapy addresses that cycle by targeting two things, the behavior and the thoughts. So we'd make a behavioral plan with that person. What are some things that you're not doing currently that you really enjoy, but you just haven't really felt like doing? Let's just do them. Let's commit to doing 3 things this week that you really enjoy. And that's called behavioral activation. On the cognitive side, this can look like catching thoughts and replacing them with things that are more helpful. So handouts I give folks often are grouped into categories of things called thinking errors, which are ways that all of our brains work to kind of protect us and anticipate danger, but oftentimes that goes a little bit into overdrive. So these are things like future telling thoughts. I'm going to be a failure, something like that. Learning how to acknowledge those as not true thoughts and as thinking errors, and catching them and replacing them with something more helpful. So that's something that we do pretty frequently. Cognitive behavioral therapy encompasses a ton of different strategies like that. Those are just 2 examples, but in short, we're working on thoughts and we're working on behaviors to improve our functioning and our mood.
Awesome. And I have a question going along with that. Mm-hmm. So the question is, I often hear about different types of therapy, cognitive behavioral therapy being the most common. Can you talk about a few different types of therapy and when they might be used?
Yeah, this is another great question. There are different, in psychology, we call them like theoretical orientations or theoretical camps of therapy. So there's cognitive behavioral or behavioral therapy. There's more psychodynamic therapy, which is what we're all probably used to seeing in pop culture, like the couch and Freud and psychoanalysis. And there are some good evidence-based treatments in the psychodynamic camp. And then we have some more humanistic interventions, which are really about connecting with the person and seeing their inner humanity and their inner good. I'm not as familiar with that one, but cognitive behavioral therapy also encompasses a large variety of specific treatments. So if you think about cognitive behavioral therapy as the umbrella, there's a bunch of treatments that fall underneath that umbrella. So we have treatments that are more manualized, like cognitive processing therapy for PTSD. We have some family therapies that fall under that cognitive behavioral umbrella. And then we have what we call third wave cognitive behavioral therapies, which are things like dialectical behavior therapy and acceptance and commitment therapy. So most of them follow the same kind of theory. They're just designed to treat different problems and kind of function a little bit differently depending on the treatment. I hope that answered the question.
I think so. The other part of the question was, are there different things we need to watch out for when referring patients to make sure they get the type that is needed?
This is a very good question and a very hard question. I think the answer is, depending on where you're at, like here in Martinsburg and in the Eastern Panhandle, if you can find someone to refer a patient to, that's already a win, because we're pretty short on behavioral health providers. And there's definitely therapies that are more helpful for patients with certain conditions. So if someone is there with PTSD, the first line treatment is some kind of trauma therapy, which could look like cognitive processing therapy, prolonged exposure. People are using EMDR for this as well. I'm not as familiar with that one. So finding a provider that has those things listed on their website or on their organization's information page. There's also, and this is the kind of thing that a lot of primary care physicians just don't have time to be searching through and finding. So if you've got a behavioral health provider in your office, they can do a lot of this work for you. But some treatment organizations have their own network provider database. So for CPT, if you're looking for a provider that treats PTSD, you can get on StrongStar, an organization through, I think it's the Department of Defense. Dr. Creasy can correct me if I'm wrong about that. And search for a provider in your area. So you can try to match provider to specific intervention if you have that kind of time. But in general, getting them in somewhere that provider can do their assessment and figure out what kind of treatment is going to be the most helpful.
And so I know there are pediatricians with us today, and there are also like medical students who are interested in pediatrics. So going along with that, do you work with the pediatric population, and what can like parents expect like out of a session with you if you were to talk to like their child?
Yeah, this is great. We have our pediatricians at our clinic in Harpers Ferry, and their residents rotating with them. So we do see the pediatric population as well. In primary care, we see anybody, any age. So I think the youngest I've had so far at Harpers Ferry has been 3, and this was just a few weeks ago. So we work a lot, if they're that young, we work a lot with the parent specifically. So if a parent comes in, which is typically when they're that tiny, it's some kind of behavioral problem. We're going to be asking a lot of questions to try to figure out what's been going on in the environment, what's happening in that child's life. Are there any changes? Are they adjusting to something? Is there any kind of like developmental condition that might be contributing to this behavior? For example, the kiddo that I saw the other day had symptoms that were consistent with like a speech or language disorder. So we referred them to get more comprehensive testing for that. So at the primary care level, if you're seeing us, it's going to be a lot of questions and maybe a referral, maybe just some parent behavior management training in the primary care setting at a pretty brief format. We've got some online resources that we send patients as well. If anyone's familiar with PCIT, there's an online through the University of Miami, a pocket PCIT training program for parents that we send out often in the clinic. There was another part of the question that I already forgot. What can parents expect? Was there something else?
Yeah, it was just what can parents expect from their child going to a session?
Yeah, and if they're older kids, I always invite the parent in, and they're always kept aware of what's going on in treatment. And we have a conversation at the beginning about the limits of confidentiality and agree on the things that are going to be shared and the things that aren't going to be shared. Always safety is going to be shared if there's any kind of safety concern. But also, sometimes parents and the kid agree, like, if you tell me that you're using substances, I want to know. And the kid might agree or might disagree, but we'll work through those issues too. And if they're older kids, a lot of the treatment looks like typical treatment for adults. So teaching kids how to catch thoughts that are unhelpful and manage those. An adorable example that I have of this is a child who was having a lot of stomach pains. So if we got kids in the office with stomach pain or headaches, usually we're getting some kind of a referral, especially if there's something going on like school starting or parents are going on a trip or something like that. So this kid had some stomach pain and they'd seen some specialists, but hadn't had any results. And these symptoms all started around the time the parents went away for a week-long trip. And then at night, she just started to get these stomach pains every night and had these fears that parents were going to just be gone in the morning and they're just going to leave her. I think she was 8 or 9. So in a couple sessions, we worked on having her catch those thoughts. So what's the thought that's really bothering you? I'm really scared my parents aren't going to be here when I wake up. Is that true? Has that ever happened? No. Okay. What's a more helpful thought? And she wrote her own helpful thought. She had some little worksheets. She laminated her worksheets with her thought and slept with them. And within a few weeks, stomach problems are gone. She's really like learned those skills well. So even kids that young can learn how to change thoughts and learn some relaxation skills and get some good tools to practice.
Awesome. Thanks for answering that. I think that's really helpful for those, especially med students who are like really interested in pediatrics, to just know that like they have the resource for someone to talk to as far as like psych help if they needed it.
Absolutely.
So another question is, how can you determine whether your patients are having long-term improvement if you're only seeing them a few times?
That is a great question. And we encounter this both on the primary care side and on the outpatient therapy side. In traditional therapy, we might see a patient for up to a few years, but then once that care ends, the expectation is that that relationship is over and we're not seeing them again. So we really don't know the long-term impacts. In primary care, we have the benefit of having patients that typically have providers they've been following up with for years or that they continue to follow up with. So if I see patients one time and they never come back and have offered them some intervention, odds are that down the road, the physician is going to see them again, and I'm either going to get to figure out what's going on or see if there's been any change. What I really rely on is the research though. So we've got some good studies and more studies coming out about these shorter term models that demonstrate that patients really can make long-term change in a short period of time and maintain that over a period of time. So that's what I rely on as kind of like the motivation or the basis for the work that I've been doing. And it's often the case that I hear from physicians that they're doing better, or we see them down the road and they're doing better. And it's also the case that they do better for a period of time, and then a few years later, something else in their life comes up and they get another referral. So that's the benefit of this lifelong care models, that we can have that relationship over time.
Awesome. So switching gears a little bit, there's some other questions in the chat, not so much about therapy, but more asking about what is like the causes of these different like mental health systems or symptoms such as like anxiety and depression. So one of the question is, do you recommend a lab evaluation on every patient, even if your suspicion is very high that the diagnosis is depression and anxiety? And can you comment on the typical lab panel obtained?
Oh, this is a hard one. I don't think I can comment on a lab panel. I don't do any of that interpretation or And I don't know if I would understand it if I looked at it. That'd be something interesting to learn. But I can say I don't recommend labs on every patient. This is another huge pro of being in the office with the physicians and the clinic staff. In the outpatient world, especially in like a community mental health outpatient system, it's pretty hard to collaborate with physicians. So being with the patient that is in the primary care office, we get to know a lot about their medical history, get to talk to their doctor. I get to know, did this just come up out of nowhere? Is there something going on in their life? What are the symptoms that they're displaying? So I'll use a variety of information to kind of make that decision, and a lot of collaboration with the physician on this part. Most of the times that I've referred patients for labs is when they're showing other symptoms of diseases. So if they've lost a lot of weight really suddenly, if they have other physical symptoms that don't seem to fit neatly with depression, there's nothing that's changed in their lives, things just aren't kind of lining up, then I'll talk more explicitly with their physician about some kind of lab panel.
All right, if Dr. Haggerty or Dr. Phillips wants to comment on that, they are family medicine physicians in Morgantown. Anything about like labs?
Yes.
No. Go ahead.
I'll jump in. So I have been lucky to practice with integrated psychology in a primary care setting. I would say that in the past, when I was doing more primary care and not as much the obesity medicine, sometimes that was determined, like I would think I'm referring for straight anxiety. And then in the discussion with the psychologists, we would come up with the idea that maybe there's an organic cause too that we should look up. Or more often, I would say I was doing that lab work from the primary care side. I mean, that was the most often thing, was that I was doing that lab work as the primary care physician and putting in the referral to psychology at the same time. I can't say I ever expected the psychologist to request labs or interpret the labs.
But sometimes they will ask for further workup.
Yeah.
Yeah, I do not run any standard panels. If somebody's just presenting with depression or anxiety, if they have other physical symptoms that are concerning, I might work that up. Like you said, the weight loss or weight gain, if they're having palpitations, things like that. But there's no real standard lab panel that we do for anxiety and depression. It's really, what's the full picture look like?
Yes.
Since I have you both, Dr. Haggerty and Dr. Phillips, maybe you could help answer this other question in the chat. The question was, how often are sodium and potassium levels related to panic or psychosis symptoms?
I cannot answer that.
You know, I don't know.
I don't really know either, but I know with severe changes in sodium levels, it can have an impact on the brain. So I suppose there might be some psychosis that comes along with that. Potassium is really more muscles, heart. So I don't know that potassium has much of an impact, but with extreme changes in sodium levels, we might see some of that, but they're going to have other symptoms as well.
I would say lab work wise, these stuff the most is of course thyroid, but of the not thyroid, vitamin D or vitamin B12 deficiency, and anemia is another one that I don't know that everybody always thinks of, but you can kind of see, and you know, people might have a more depressed mood or fatigue related to that one.
Yeah, I've definitely seen psychiatrists checking thyroid and vitamin D more often.
Yeah. Now, I'd always said vitamin D caused depression, and then a resident challenged me on that a couple years ago. And looking at the data, they didn't seem to have much out there that vitamin D did, but I still check vitamin D, especially for fatigue and depressed mood. But I don't know if that's just trained into me, and maybe it's not realistic, but I do it.
I think it's a standard part of the fatigue workup at the very least, especially around here. I mean, there's a very high percentage of people in West Virginia and the surrounding areas that have a vitamin D deficiency. So around here, it's going to be a very common part of the fatigue workup. And so if one of their depressive symptoms is fatigue, it might be something that we consider.
Yeah, so I still do it for sure, but I did get challenged on that and forced myself to look at the research, and it's not as clear as I thought it had been.
Well, thanks for chiming in. I appreciate it. And Dr. Neal said vitamin D research is very much still a work in progress. So
I would definitely.
Nothing set in stone about that. All right, Dr. Deamer, another question for you. I think you touched on it a little bit when you were talking at the beginning, but the question is, for those who may not know, what's the benefit of referring to therapy for chronic pain?
Ooh, yes. So I am just starting to enter the chronic pain world, and there's lots of really great psychologists that are just pain psychologists that have a lot of information. So I'll preface this by saying I'm very early into the chronic pain research, but we know that pain has a bidirectional relationship. So our pain impacts our mood, and also our mood and anxiety impact our pain. So folks that have kind of co-occurring mood and anxiety disorders can really benefit over the long term by managing those conditions as well. And a lot of times we see patients really starting to shrink their world because of their pain, which exacerbates mood conditions as well. So if patients are decreasing their activity or not doing things with others, not leaving the home, working with the patient to maybe challenge some of their assumptions about, I mean, if they have physical limitations, that's one thing, but if it's something more chronic, talking about managing their pain on a day-by-day basis and doing as much activity as they can each day. I've recently been introduced to spoon theory, which is, I think, a cool way of talking to patients about it. Idea that every morning you wake up and you have a certain number of spoons of energy based on your pain level. And we want to make sure by the end of the day, we're using all those spoons, whether or not it's a 10 spoon day or a 3 spoon day. We want to be using what we have every day. We talk about activity pacing a lot as well. So the idea that if you're really engaged on a certain day, kind of expecting to have a slower day the next day, or managing the results of that and not necessarily catastrophizing that. So people who've got chronic pain can have lots of pain catastrophizing thoughts that we can work on. They can also have fears of moving that we can work on, in addition to mood and anxiety that might be co-occurring.
Well, great. Thanks so much, everyone, for your questions today. Thank you, Dr. Deamer, for giving such great and thoughtful answers today. I have a couple more questions, because I think the big topic today was like dealing with anxiety and depression, and like how can you help, and how can other people get the help that they do need to help them through this. So one of the questions was, what are some home tips that you can give to patients for anxiety and depression? I know you mentioned like you have some handouts, but if you could just like give us a rundown of some things that people could maybe think about doing on their own as they like finish the talk today, finish their walk today.
Yeah, this is a lot of what I do on a day-to-day basis, just kind of giving people some things to do at home. And since we've got some medical students on here, I imagine I was a student myself. It's a stressful time. So we can all benefit from incorporating some of these things into our daily life. But for panic specifically, so if we've got anxiety symptoms to the point where we're feeling some physical symptoms as well, I teach a lot of skills called the TIP skills. And this is an acronym for temperature, intense exercise, pace breathing, and progressive muscle relaxation. So those 4 skills I'm teaching constantly in the clinic, and oftentimes we're doing them in the room together before the patient leaves so they can feel the impact of that. The temperature one is either splashing your face with cold water, putting your face in a bucket of cold water if you can, or a cold compress across your eyes, and holding your breath for a period of 10 to 15 seconds, or as long as you comfortably can. That mimics the die reflex. So our heart rate drops, we start to calm down. I tell patients that they might need to do multiple cycles of this, but I encourage folks, if they're experiencing either a really intense emotion like anger or sadness or panic, to try that out a few times and see if that helps. I encourage a lot of regular intense exercise. Even if it's just a 20-minute brisk walk, if you're someone who's managing depression and anxiety, really daily cardio exercise if you can, just to get the heart pumping. I've had people get really creative with this. So someone told me when they started to feel a little panicky, they would just do as many push-ups as they could as quickly as they can, or do as many jumping jacks as they could as quickly as they can. The paced breathing, my favorite is called square breathing. So breathing in for 4 seconds, pausing and holding your breath for 4 seconds, out for 4 seconds, holding for 4 seconds. But in general, anything that helps you focus on the exhale. Patients always say, yeah, I know, take a deep breath, like take a bunch of breaths in. I say, actually, that's getting towards hyperventilating. That's actually increasing your heart rate. It's doing the opposite of what you want. So let's focus on exhaling longer than we're inhaling. So you could simply do like 3 seconds in, 6 seconds out, or something along those lines. And this takes like 2 to 3 minutes. So if you're really trying to calm yourself down or manage some stress, setting a timer and doing this for at least 2 to 3 minutes, and rating yourself on a number 1 to 10 before and after, so you get that reinforcement of how effective it was. I do that a lot in the office with patients before they leave, but I also use it myself regularly, so it does work. And then the last one is progressive muscle relaxation, which is clenching and tightening different body parts so that you can feel the physical relaxation in your muscles. I also use this frequently in my neck and in my shoulders. If you get tension headaches ever, this can help kind of relax all of that up there. With depression, the things that I encourage people to really work on is just behavioral activation. So doing things regularly in your life that are important to you, whether that's in your community or with family or hobbies, exercise, just really focusing on pleasant events in your life if you don't have enough of them, or increasing your activity if you're kind of laying in bed and being very stagnant throughout your week. It's got some really great research support around just getting more engaged and more involved in your life. And then anxiety, more generalized anxiety, I really emphasize thoughts. So worries and thoughts are typically what maintains a lot of the anxiety symptoms. So some people really respond well to something called worry time, which is when you have worries pop up in your head, you acknowledge that they're there, and you write them down, or you text yourself, or you put them in a note, and you dedicate a time during the day where you just worry about that for however long you need, an hour. You have to have a time limit on it. This can't be all night, but 30 minutes, an hour is your worry time. And then after that, you save your worries for that time the next day. Other things like catching thoughts and replacing them with more helpful thoughts, or simply asking yourself a question like, is this thought helpful for me right now and for my goals right now? Are some things that you can do on your own that can manage those symptoms.
Great. I think those were some really awesome tips. So thanks for like talking us through them. I hope that this talk benefited people out there listening, whether you're a med student, whether you're a practicing physician, or just someone in the community. Thanks for joining us. And I hope that you're impacted and can help to change your life in little ways by coming on this walk today. Dr. Deamer, I just want to thank you so much for joining us from Martinsburg, West Virginia. It's so nice to see people out and about. If you could just like wrap up your talk with like 3 points today for someone who's listening, or you think someone could benefit from the talk, what are 3 things you think you could summarize your talk today with?
Yeah, I think the key takeaway is that our physical health is impacted by our mental health and vice versa. So there's behaviors and things going on in our life that really impact our health, and our health can impact our physical health as well. Second key point is that if you are a medical resident or a physician or someone who is in a setting that's caring for patients, we would love to be a part of that and be involved in the care of your patients and collaborate with you guys. It's the most rewarding work I've ever done in a primary care setting, because patients really do come in with acute needs to primary care, and in many clinics, behavioral health providers are just not there and they're not present. So if you're at a clinic that doesn't have one of us, let me know. I can help advocate. I know some organizations that are reaching out and trying to expand and add behavioral health providers in different clinics as well. And then third, all of us can really benefit from doing some of these simple strategies that we teach patients every day. I use them constantly. I had to use them last night as I was worrying, as I was sleeping. Like, okay, this is something that you're currently sleeping right now. Save that for a later date. So they're just as helpful for us with our busy and hectic lives as they can be for patients. So thank you so much for having me today. This has been great.
Yes, thank you so much for joining us. I'm sorry we didn't get to every question in the chat today. If you want to stick around, we can still ask some of those questions. I feel like Dr. Haggerty and Dr. Phillips might be able to answer. There was a question about supplements, if someone's so interested in learning about those, and we could talk a little bit about that. And then there was another question on kind of like the opioid crisis in West Virginia. Unless you wanted to touch on those, Dr. Deamer, before we wrap up. Any thoughts on like supplements or how depression plays a role in the opioid crisis in West Virginia?
I do not have a lot of information on either of those, so I'm happy to pass that off.
Okay, well, we'll just kind of wrap up the walk today by thanking everyone for joining us, whether it's sunny outside, whether it's rainy. Thanks so much for getting active and getting your steps in on this Saturday morning. We love seeing people out and about. So our next walk will be in 2 weeks. And it will be half in person and half virtual. So if you're still joining us virtually, same place, same time, join us on Zoom. If you are walking with us today, if you wouldn't mind opening up the chat function right now, typing who you are and where you're walking from, we'd love to see how far our program reached. I'm happy to see some familiar names on the participants list today and some new names. So I welcome everybody who's joining us for the first time. I hope that you enjoyed the walk today, got a lot out of it, are inspired to make a difference in yourself and in your own health, and just keep on moving. Our walks are audio recorded and posted to our YouTube page. So if you feel someone else might benefit from this talk today, send them over to our YouTube page, encourage them to go for a walk too, and take their headphones with them and listen to our talk. All right, thanks so much, everybody.